So good afternoon, everyone, and welcome to the 66th episode of Mrftt HIV STI Echo. Hopefully, with what's going in Russia, this won't be the last Mrftt HIV STI Echo. I hope you're all well and at peace. We need to do some praying because the world is becoming crazier as we speak. But thank you for taking the time out of your busy to spend with us. I am Dr. Gregory Boyce. I am your host for today, and today we're going to have a conversation linked to a previous session we would have done on actually something called fatty liver disease, because one of the things that's an active area of research right now is weight gain in persons living with HIV, and how that links to everything else in terms of medication, in terms of long-term prognosis, in terms of non-communicable disease, and the burden that would have both on the healthcare system and individual patients. So I thought we should have a conversation about that today, and see where we go in terms of programming in the future for monitoring of patients, especially since we're now switching a lot of our patients to dolutegravir-containing regimens, and what that would mean in terms of how we follow them up in the upcoming months short term. So I'll just start sharing the presentation now. And we're just going to again thank ITEC and University of New Mexico for their support in hosting and running this Echo series. I have disclosures. And so we're going to speak today, hopefully, about discuss the prevalence of overweight and obesity. We're going to discuss the mechanisms that contribute to weight gain among persons living with HIV, and outline the management of overweight and obesity, just briefly, among persons living with HIV. So in the PreART era, the focus was essential on maintaining weight. We knew about wasting syndrome and people becoming emaciated as a result of advanced HIV disease. And when in 1996 ART became available in a form that was able to maintain long-lasting suppression of virus, we were able to finally to actually have people recover from advanced disease. But a lot of the early drugs were fairly toxic, lots of side effects. And one of those side effects was fat distribution abnormalities, like atrophy, which is fast fat wasting, which you would see, I think, A, B, and C, where you get wasting of peripheral fat, especially face limbs, and lipohypertrophy, which is accumulation of fat, usually centrally. So you see that in D, what they call that buffalo hump, or the dorsocervical fat pad, and abdominal obesity. I think they call it Crick's belly, that was the name of it, after one of the medications that tend to cause the early protease inhibitor called Crixivan. But with newer agents, the side effect profile was much improved. It became much less toxic and better tolerated. But there's been a recent focus, especially with some of these second-generation integrase inhibitors like bictegravir, dolutegravir, on weight gain in HIV, and the influence of antiretroviral therapy has on weight gain. In addition to integrase inhibitors, there's also a drug called alafenamide, which is a newer version of one of the backbone drugs called tenofovir, and the realization with one of the trials with dolutegravir actually that drug was linked to weight gain. So we were still trying to figure out why weight gain occurs with these drugs. What is the precise mechanism by which it does so? Who is at risk? Is there a profile you can generate as to who will get varying amounts of weight gain? Can it be prevented? How do we manage? Particularly given that we know all the linkages between weight gain, obesity, and non-communicable disease. So just by way of overview, we know that obesity is a global issue and has been getting worse over the last several years. There are currently about almost 1/3 of the population of Earth is either overweight or obese. There's 650 million people living with obesity as we speak, more so in women than in men. The prevalence of obesity has tripled over the last 40 years, and obesity was once considered to be a problem primarily of developed countries, but right now, some of the places on Earth with the highest rates of obesity are actually in what we call the developing world, right? And this curve just shows the trend in obesity rates, both in the United States, which is one of the world leaders of obesity, and elsewhere in the world, showing that over the last, again, 30 years, it's been increasing steadily. In terms of persons with HIV, remember they would come from general population, so the median body mass index, or BMI, at initiation of antiretroviral therapy increased from 23.8 to 24.8 between 1990s and 2010 in a large cohort of patients, primarily in the United States and Canada. And the percentage of those patients that were obese at initial presentation doubled over the period from the same period from 1990 to 2010. So from 9% to 18%, and still increasing subsequently. And what are the contributing factors? So separate and apart from all the issues around HIV and how that contributes to changes in fat metabolism because of inflammation and dysbiosis and all those other things we spoke about when we spoke about non-communicable disease and fatty liver disease, we have to think about cultural and ethnic and even personal approaches to diet and exercise and substance use, whether it be smoking or alcohol or illicit drugs. When we think about mental health, depression and stigma, and the drugs that you would use to treat mental health disorders, a lot of the antidepressants and antipsychotics are linked to weight gain. Right? And we have to think as well about each of these specific factors, whether that be, as I spoke to before, inflammatory disease, microbial translocation, not just adipose tissue distribution, but as well the type of fat. One of the things that is currently under investigation is when persons regain fat, what type of fat is the fat that they regain metabolically normal, metabolically active, and what does it do? Remember, fat is not a silent organism, it produces hormones, it affects the metabolism of the rest of the body. And that is an important thing to keep in mind when we talk about overweight and obesity. And I think the complications of obesity are well rehearsed. You know about all the cardiovascular complications, gastrointestinal cancers, whether it's gynecological or non-gynecological, the impact on the joints, on cardiovascular disease, and on liver disease, again, make a little plug. You check the YouTube channel for the presentation on non-alcoholic steatohepatitis, as well as pulmonary disease. We don't often think about whether it's restrictive lung disease, what we call Pickwickian syndrome, or obstructive sleep apnea, and all the implications of obstructive sleep apnea, including refractory hypertension, all these different things, right? Of note, similar again to fatty liver disease, where we talk about slim NASH, that you would expect fatty liver disease in overweight people, but in HIV, you can actually get fatty liver disease in slim persons, similar diabetes, that there was a higher prevalence of diabetes in persons living with HIV at comparable BMIs to those who are HIV negative. So you get diabetogenesis at lower body mass index. And additionally, pound for pound, the risk of developing diabetes per pound of weight gain in someone who's living with HIV versus someone who's HIV negative, the risk is twice as high among persons living with HIV of developing incident diabetes. And that's an important factor to note as well. And when we think about weight gain persons living with HIV, we think about, and it was theorized for a long time, as quote unquote refeeding syndrome or return to health. So when someone who's living with HIV is naive, they haven't started treatment yet, remember, there are certain metabolic compensations that the human body undergoes to fight off a constant infection, that the basal metabolic rate is higher, there may be a loss of appetite because of infections or the disease. There's reduced protein deposition and increased fat mobilization because the body is essentially in a catabolic state, right? And depending on various issues respected to gut permeability and gut disease, there may even be reduced nutrient absorption. So essentially the body is primed to either remain at a low weight or lose weight gradually over time because it's this constant fight against the virus. You start antiretroviral therapy, a lot of that shuts down. So the body then goes into a state of reversal of that catabolic state, right? Because the energy requirements are now much lower. You may get increase in appetite and better food absorption because the person is no longer as ill as they used to be. And that results in varying levels of reconstitution of the fat that may have been lost during the previous period. the question often is where that fat will be distributed in the body. We'll come to that a little later. And in addition, the microbiome, the composition of the bacterial flora in the gut may improve, but never completely normalizes. But even that may have a positive impact on weight gain. Now, that being said, as we mentioned before, that the fact of weight gain does not necessarily reduce some of the underlying pathology in terms of this metabolism of this virus and all the perturbations that accompany living with HIV, even on long-term suppressive therapy. So there is still the essence of insulin resistance, liver fibrosis, again, talk about fatty liver disease, coronary artery disease, frailty, including sarcopenic obesity. What that means is that you can actually get deposition of fat in muscle tissue. So you actually get relative reduction of muscle mass because a lot of muscle mass is replaced by fat, and it may be irreversible. Right? So let's talk about in persons who initiate therapy, what is the rate at which they regain weight? Now, as we get older, and unfortunately I am a good example of this, sadly, we all tend to put on weight gradually over time, as a population generally speaking. What was found in this study, which is a 12-year study, where they followed persons where there was weight data available in their records, followed their rates of weight gain over time for both persons with HIV who started treatment and HIV negative controls. And what they found was that persons with HIV, their rate of weight increase was 3 times that of the HIV negative cohort. So at the end of the study, there was no significant difference in weight. So you see BMI at the beginning was HIV negative was 28.7, HIV positive 25.8, and by the end of the 12-year period, HIV positive was 28.4, HIV negative 29.4, which was not statistically significant. And it's a very large study. You see 120, almost 130,000 negative persons, over 8,000 persons with HIV. So that was some fairly robust data. And you would think that, obviously, persons with HIV, they're gaining weight because, on average, they may have people who are ill, who may be emaciated, and that kind of pushes up the average. So these are ill people putting back on weight. So that's not neat. But what they went on to do was to analyze, based on starting BMI, what the rate of weight gain was. And regardless of starting BMI, whether normal or underweight, overweight, or even obese, there was a consistent trend of weight gain, even in the obese population, where you would find, for example, the average BMI in the HIV negative persons was essentially unchanged, 33.5 to 33.2 over that 10-year period. There was a trend towards an increase in weight, even though it wasn't statistically significant, it was still numerically, there was a slight trend towards increasing weight among persons with HIV starting treatment while in the obese BMI range. Now, what this study did, so this is a sort of a meta-analysis of 8 separate clinical trials of starting treatment in patients who are HIV naive for different types of drugs over the period 2003 to 2015, comparing and we'll pull all the numbers and see what we're going to get, comparing the rates of weight gain and subdividing by gender, by ethnicity, and by gender and ethnicity. And what they found was the same general increase in mean weight over the period of time, over 96 weeks, of about just over 2.5 kilograms. And again, women more than men, and that was statistically significant. And in terms of ethnicity, persons who are of Black versus those who are non-Black, there was, again, a trend towards persons who are Black having greater weight gain than persons who are non-Black. And far to the chart to the far right, Black women especially underwent the most weight gain, followed by Black men, then non-Black male and female. That was not significant, they were about the same. So there's a gender disparity, both in terms of Black women and Black men, as well as this Black men and women in general over non-Black women and men. Now, and the study was also large enough to tease out the differences in anchor drug, which means if it's a non-nucleoside protease inhibitor or an integrase inhibitor, as well as some of the backbone drugs, so these idovudine, tenofovir, abacavir, and so forth. And what they found was that, again, on the chart to the left, integrase inhibitors as a group, persons who started integrase inhibitors had the most weight gain, followed by persons who had protease inhibitors and non-nucleosides. I don't think the difference was significant at 14 and 96 weeks for protease inhibitors and non-nucleoside or reverse transcriptase inhibitors, but it was at 96 weeks for integrase inhibitors. And in terms of the integrase inhibitors, whether it's bictegravir, dolutegravir, or an older integrase inhibitor called L-vitegravir, right? There was a significant difference between L-vitegravir and bictegravir and dolutegravir. With bictegravir and dolutegravir, persons who started on those drugs having more weight gain. And again, in terms of the nucleoside backbone, and this was one thing that was not fairly recently known, but at least known for a couple of years now, that tenofovir alafenamide, which is a newer version of tenofovir than the one we're accustomed to, that's in, let's say, what you call a tripler, or even now with the tenofovir lamivudine dolutegravir single dose tablet, which is tenofovir disoproxil. So the newer version of tenofovir is linked to the highest amount of weight gain, followed by abacavir, interestingly, followed by tenofovir disoproxil, which is tenofovir classic, and then zidovudine, which is not used as much now in terms of initial therapy. But that was it was about weight neutral over 96 weeks. And this study, which is the advanced study, is kind of one of the studies that sounded the alarm bell, I think, the loudest fairly recent, in that the study was done to compare outcomes of what was standard of care at the time, which was tenofovir, binifavirin, versus dolutegravir, emricitabine, and tenofovir disoproxil, tenofovir classic, versus tenofovir alafenamide. And what they found was that there was a weight gain in persons who started tenofovir alafenamide, which was the highest weight gain, especially in men, but plateaued at 96 weeks at 5 kilograms. Tenofovir disoproxil, there was a 4 kilogram weight increase over 96 weeks. And if efavirin-based regimen, there was just a 1 kilogram increase in weight, so that was not very much. And that was in men. In women, the increase at the end of 96 weeks for persons who had a tenofovir alafenamide containing regimen with dolutegravir was 10 kilograms, and it wasn't plateauing, right? You can see slope is still heading up. And that is significant. So imagine if you put on 10 kilograms in 2 years, what that would feel like, right? And still increasing, given that you haven't changed anything else about your diet, your dietary plans, anything else, if it's on 10 kilograms. That is very significant. And potentially, when we think about the burden of non-communicable disease moving forward, something that we have to think about very carefully. And we are transitioning to dolutegravir as we speak in Trinidad and Tobago, but not tenofovir alafenamide, tenofovir disoproxil, right? Which would be the second, the light blue line here. But still, at the end of 96 weeks, the weight increase was 5 kilograms, which is, again, significant. Now, one of the things that came out during the research was that there are various enzyme systems that are used to break down drugs in the liver. And there's a particular enzyme system called CYP, or cytochrome 2b6. And that breaks down efavirenz. But different persons have different activities of that enzyme. So persons who have who are fast metabolizers, in other words, they say the CYP 2b6 system is very active. Their efavirenz exposure tends to be lower, right? Versus slow metabolizers who have a higher efavirenz exposure. And what they found was that the persons who were what we call extensive metabolizers of efavirenz, at the end of 48 weeks, their weight gain was similar to that of dolutegravir. And what that suggested was that there was an effect of efavirenz in weight in mediating weight gain, not so much by driving weight gain, but actually by possibly promoting either weight maintenance or weight loss. And how that was theorized is that in persons who have the slowest metabolism of efavirenz and therefore the most extensive efavirenz exposure, when you take them off efavirenz and put them on dolutegravir, they experience the most weight gain, which means there was something about the efavirenz that was holding down their weight. And that was not completely understood. Why would that be? And so with a lot of the conversation around weight gain in persons with HIV on antiretroviral therapy is this true weight gain, or is this a loss of weight loss? If you can understand that dichotomy. Is it that if we switch persons off of medications like tenofovir, disoproxil, like efavirenz, that seems to be keeping their weight depressed, and switch them to another agent, the weight gain that occurs, is that as a result of the new agent increasing weight, or the older agents having put the brakes on weight and weight increase over time? What you just get is that person catching up to the weight they would have been anyway, right? And this chart here actually, expresses it pretty nicely. So the upper cohort is actually, over 100,000 persons in the United States, about 8% of all the people living with HIV in the US. And their weight was monitored. And based on the drug that they were on when they switched up tenofovir containing regimen. So the only thing that was changed was the version of tenofovir that they were using. So the anchor drug remained the same, right? The other drug in the nucleoside backbone remained the same, but it switched from tenofovir disoproxil to tenofovir alafenamide. So the change in weight was due only to change in version of tenofovir. And what it shows essentially is that at time zero on these three charts, whether the person was on integrase, or non-nucleoside, or boosted protease inhibitor, time zero is when it switched from TDF to TAF, tenofovir diproxil to tenofovir alafenamide. And there was a weight gain if you were on an integrase and switched to tenofovir alafenamide of about 2.6 kilograms from time 0 to time 9 months. If you're on the nucleoside, about 2.25 kilograms, and then 1.9 for the boosted protease inhibitor. But after that, 9+ months out from the switch from tenofovir disoproxil to tenofovir alafenamide, you get a leveling off, right? So it's flat before, you get an inflection that sort of catch up weight gain and then flattening again. So this is one of the things that we may have to counsel our patients about when we're changing regimens, and we know there may be a change in weight, advising that look at it may be just temporary depending on the agent we're using. Remember with dolutegravir in women, the weight didn't level off as it did in men. So one of the things we have to allow patients to anticipate and understand what may happen to their weight moving forward. Now, this didn't come out completely clear, and I apologize for that. But what this is the change in weight of persons who are on pre-exposure prophylaxis, either with emtricitabine, tenofovir, disoproxil, TDF, or emtricitabine, tenofovir, alafenamide, TAF. And these are persons who are HIV negative, so there's no contribution of the HIV status to change in weight. And what was found was that, for example, in the IPREC study, for persons who were on emtricitabine, tenofovir, disoproxil, there was actually a downward trend in weight over the 48 weeks when they were on tenofovir containing PreART as compared to placebo. With the Discover trial, when they were on two different forms of tenofovir disoproxil, there was essentially no change in weight, but noted that tenofovir alafenamide was an increase in weight. So there is something about the molecule itself, even in persons who are HIV negative, that is contributing to change in weight. With HPTN-077, this is cabotegravir versus placebo. The weight there was not much difference in weight, not statistically significant over the period of time. And when we talk about weight gain, we have to be very mindful. And this is one of the things that came out during the reading, that not all weight gain is the same. Right? So this scan here is of two individuals who have equal body mass index. The BMI is identical. Right? But if you notice the person A SAT stands for subcutaneous adipose tissue. VAT stands for visceral adipose tissue. Now, visceral adipose tissue is metabolically active. It does things to affect things like insulin resistance and lipid levels, and can affect, it's actually metabolically adverse in terms of what it does. If you get a lot of visceral adipose tissue accumulating, but that's the fatty tissue around things like your abdomen and around your pericardium and your liver and all over the place. Subcutaneous adipose tissue is metabolically more benign, right? So that in persons who gain weight and they gain a lot of subcutaneous adipose tissue, that would have a less of a metabolic impact, than somebody who regains a lot of weight, but mostly visceral adipose tissue. So BMI doesn't capture that change well enough, right? BMI would just tell you, well, okay, this person is, weight over height square meters, and just get a number. But it doesn't give you information as to what is the difference in one person's risk from cardiometabolic disease versus the other. And one of the things that they found that in persons who regain weight on an integration inhibitor tend to, but this is highly variable and completely unpredictable. So you can't tell from person to person who gets more subcutaneous adipose tissue and who gets more visceral adipose tissue, right? But the persons who gain on integration tend to get more subcutaneous adipose tissue. So only worry about, well, this person has put on 10 kilograms, but that's mostly subcutaneous. It doesn't carry the same metabolic impact. And in terms of what might contribute to some of the differences in weight gain on antiretrovirals, there was a possibility that between tenofovir disoproxil and tenofovir you get more nausea, possibly with tenofovir disoproxil that might affect appetite and food intake, and that might thereby indirectly contribute to the not so much weight loss, but fear of weight gain with tenofovir disoproxil compared to alafenamide. There was a possibility that nucleosides in general may affect gut microbiome. But remember, the microbiome affects things in terms like fat absorption, that sort of thing, to the vitamin K generation. Tenofovir disoproxil binds lipids in the gut, so there is a possibility that by binding lipids in the gut, you absorb less of it, and therefore you get less adipose tissue creation from lipid metabolism. And there is a possibility that there may be unknown effects or some newer agents on CNS receptors like serotonin receptors and dopamine receptors. Because one of the things that is known is that in the same way as you have liver enzyme systems that metabolize efavirenz, and based on the activity of those enzyme systems, you can get differentials in terms of side effects and even weight. With, for example, dolutegravir, there is a liver system called UGT1A1 that is prominent in the metabolism of dolutegravir, and based on the activity of that system, you can actually get a difference in terms of CNS side effects, but not weight gain, interestingly, right? But if there are, and there is actually some evidence that dolutegravir binds certain receptors in the brain, certain receptors that control metabolism. If there are differences in the binding based on those polymorphisms, it might affect, in a way we can't quite understand how persons with HIV, for example, how they metabolize food, whether they have a strong appetite drive, what foods they choose, and that sort of thing. Now, there is still an ongoing debate about body mass index, because there are studies in different parts of the world that show, for example, the lowest mortality with BMI in some places 35. Right? We in the West we think about BMI greater than 30 is obese, so we should do something about it. But there are certain populations who are under study where the inflection point for mortality is like 30 to 35. Right? And if you're lower than that, actually mortality is higher, not lower. So we don't fully understand how BMI and as imperfect a tool as it is, links to mortality in diverse populations. And as I spoke to before, we don't even know how useful BMI even is, because as highlighted earlier, the person that had subacute versus visceral adiposity with identical BMI, one person is at a much higher risk of cardiometabolic disease as opposed to the other. And therefore, one person requires much different and much more intensive intervention as opposed to the other. And in terms of how do we think about those risks, DEXA scanning for estimation of subacute versus visceral adipose tissue assessing cardiometabolic risk. It can very efficiently do that, but the question is, what is the applicability of that? Because those scans are not generally available easily in places with the highest burden of disease, which is one of the recurring themes when it comes to management of HIV. So just a brief comment on management of weight gain and obesity. We have to be very mindful about stigmatizing persons who are living with obesity. It is not a character flaw, it's not laziness. We shouldn't be badgering them, why are you losing weight, you're eating trial, and you start eating all that stuff. No. And there's a very good actual review article about how weight is stigmatized the same way as HIV is stigmatized, even by medical professionals. Right? I remember as a junior doctor, one of my consultants, I won't even repeat what he said to this person, but it was so insulting and so demeaning. Right? And the patient, it was a middle-aged lady, she was in tears. She was insulted by this consultant because she was overweight. Right? We need to move away from that. I think this is one of the things that is unspoken, unaddressed, and it needs to be addressed. Right? We need to counsel patients early regarding the potential for weight gain, especially in the medications we put them on. Because if someone is of the opinion that, look, I would prefer not to risk any further weight gain, I'm already having my estrogen, if you tell me this has the potential to cause me to gain weight, allow them to make that informed choice. There is some benefit for intensive lifestyle modification with diet and exercise, but the approach should be a lifestyle approach. We're not doing that to lose the weight, because when you lose the weight, then you don't need to do it anymore, right? No. It has to be unlinked from weight. Because there are persons, and again, there was this debate on metabolically healthy obese. Someone who is, eating, exercising, healthy, running marathons, all that sort of thing, but falls out of this BMI threshold that medicine has created. And despite the fact that they're doing all the things that would count towards a healthy lifestyle, we are still, as professionals, condemning them because their weight falls outside the strategic range. We need to manage for metabolic complications, whether those are lipids, glucose, or blood sugar. There are some new pharmacotherapeutic agents that have been FDA approved for management of weight, and the science is moving towards thinking of obesity as a chronic disease, in the sense that if you're on anti-obesity medication, this is you manage the same sort of way as you would manage someone who's diabetic or hypertensive. This is a condition that you have, and you need to be on medication lifelong or long term. Bariatric surgery, which is just things like gastric sleeve and that sort of thing, and gastric banding, is extremely effective, but expensive and sometimes dangerous. So it needs to be reserved for persons who are at significant risk due to their obesity, and definitely needs to be done in the context of a multidisciplinary approach to dealing with their weight issues. And final thought, ART switches for weight gain have generally not been found to be helpful. So it becomes a matter more of management of the lifestyle issues as opposed to switching medication, which is counterintuitive by the research and severity. So I'll just summarize that weight gain in persons living with HIV is complex and not fully understood phenomenon. The impact of newer agents on weight gain is still being assessed. And management of weight gain requires a non-judgmental team approach in order to be as successful as possible. And I think I'll just sum it up there. Thank you for your attention, and just open the floor for any questions anyone might have.
Uh, Thanks, Dr. Boyce. I think I want to jump in with a question right away. I am hearing more and more about plant-based diets, and I wonder if this is too radical a change for PLHIVs who might have concerns about weight gain.
So it's a little bit difficult when it comes to diet. Yes, there are, there's definitely a role for dietary approaches to weight control. Plant-based diets in general have found to have benefits in terms of insulin resistance and even cholesterol and that sort of thing. I don't think it's too extreme, but I think it does need to be done in context of general lifestyle changes. That's, just tweaking it, that in the absence of other lifestyle interventions like activity and exercise would probably not be enough and might not be sustainable over time. And one of my concerns when it comes to plant-based diet is that it does require some amount of investment of time to make sure that you're getting all nutrients you need, because there are some trace nutrients that you cannot get through a plant-based diet. So that has to be done carefully to make sure you don't run yourself into micronutrient deficiency. So I'm not necessarily opposed to it. I don't think it's too radical, but it just needs to be done carefully and in the context of healthy lifestyle changes.
Great, thanks for that.
Let me just add another side to it, and this may be from personal experience. Plant-based diet tends to make people lose weight initially, but as they continue on the same diet, actually the weight goes back to what it was before and they keep it there. The other difficulty about weight and diet is sometimes we tell people what they should eat and what they should not eat, but they have not decided to do so. So it becomes very difficult to implement. And then there's this group of people who go through basically starvation process. They get some prescriptions from non-doctors, basically based on drinking water with no nutritional value, and naturally they lose weight without asking themselves, once they finish the process within a few weeks, what happens next? And then sometimes when we are talking to somebody who looks or seems like they have some weight, it pays also to ask, what was your weight the last 5 or 10 years? And then if somebody has been with that weight from the time they're about 20 or 25 years old, then the only thing you remain to work with is for them to lead a healthy lifestyle with the same weight, but at least they can be more agile, more active, exercise, and so on.
Thanks, Dr. Wilson. All right. Any other comments or queries? Oh, I'm sorry. Oh, sorry, I'm making out a very strange noise. I apologize.
Yes, one question. Amongst the medications that lead to weight gain, and what I remember is that most of the times the weight gain is about 5 to 10%. Are there any medications that make people maybe gain 20, 30% of the original weight?
Well, so far, not yet. Well, not across the board. There are persons who would have large amounts of weight gain, and this is one of the things that is difficult because we don't know from person to person. There's no algorithm we can apply to say that, okay, this person is going to put on 5 pounds, 10 pounds, well, kilograms, sorry, or none at all. So, for example, in the dolutegravir example, in the advanced trial, at the end of 96 weeks, the average, right, weight gain was 10 kilograms, right? So imagine if your starting weight is 50 kilograms, right? That's what That's a significant fraction of your weight. Right? And the fact that that's the average means there are people higher than that. So it's, even though it wouldn't be consistent that this person, this particular agent causes 20 to 30% weight gain. And if there was such an agent, I suspect it might be withdrawn, because that is excessive weight gain that's pushing people into obesity. And the long-term consequences of that might be catastrophic. It might happen as I said, in a short period of time that they would do these follow-up studies for 96, 144 weeks. But 5 years down the road, especially, for example, with the Gregory case in women where there was no plateau, it's still going at the end of 96 weeks, what is going to happen to those women long term, right, in terms of insulin diabetes, metabolic syndrome, cardiovascular risk, and that sort of thing. Okay, well, we do not have a case today, so absent any further comments or queries, I think we'll tie it up today. Again, I thank everyone for coming. It's a really good turnout today. Our next session will be in 2 weeks' time. We will send out our notifications. We very much appreciate your presence. Again, let's all pray for peace, because today was a bit scary morning, and we shall see you back in 2 weeks' time. We appreciate you, and that is for Mrftt HB Echo. Take care and stay safe. Bye.
Thank you, Gregory.